Welcome to Tower Direct's Norepinephrine for ALS Education. Take it away, Jared.
We'll start with the objectives. The goal of this course is to make you comfortable with being able to describe the indications, dosing, and treatment goals of norepinephrine with an understanding of the common premix concentrations that are available, as well as having a basic comprehension of the pump programming and fixed-rate infusions. Norepinephrine, or the brand name Levophed, also commonly referred to as Levo, is a vasoactive medication, typically referred to as a vasopressor or a pressor. It works primarily as a strong alpha-1 receptor, which gets us that therapeutic vasoconstriction. It also has a mild beta receptor effect, which is typically seen in higher doses, which can impact the heart rate. Its onset is almost immediate, and its peak or steady serum state is about 5 minutes. It also wears off very quickly, the half-life being 2 to 3 minutes, and this makes it a very titratable medication for EMS practice. The current indications are for multiple shock states, as well as post-ROSC supportive care. The contraindications are fairly vague in true life-threatening emergencies, but if you do have a patient with known active DVTs, it's best to proceed with caution. The side effects, like discussed earlier, are typically associated with higher dosing. Patients can develop tachyarrhythmias the longer the infusion or the higher the dosing. Current indications are for ALS interfacility transport, as well as 3 specific protocols for field use. Today we'll be referring to the PA protocols for shock and post-ROSC care with an updated Tower Direct best practice for shock management. We'll go over the shock protocol in depth in a few slides, but first let's take a look at the blood pressure goals. For shock patients, we're looking to target a MAP of greater than 65 with a systolic blood pressure greater than 90. For post-ROSC patients, that number is further increased to a MAP greater than 80 and a systolic greater than 110. With shock states being so hypoperfusive, the goal here is to start reperfusing the end organs as aggressively and as soon as possible. A quick review on MAP, or mean arterial pressure. It's a mathematical function of systolic and diastolic pressure seen below. We can see that 2 times the diastolic plus the systolic divided by 3 gets us our MAP. And why do we care so much about MAP? Well, our primary tool for assessing blood pressure in the field uses technology that finds the MAP first and then algorithmically generates the systolic and diastolic based on multiple samples after that. This leads to the MAP from the LifePak 15 being more accurate than the systolic and the diastolic. We also know that titrating just to a systolic can lead to undertreating patients whose MAPs might be below our therapeutic goals. As a reminder, you can always find MAP on the LifePak 15 in the bottom left corner, as circled in the indicator on this slide. Okay, now we're going to cover the updated Tower shock protocol. We're going to start this with patients that are 14 or older. You're going to need access, and you're going to need the appropriate supplies. To start, we're going to rapidly infuse a 500 milliliter normal saline bolus. Pressure bags are in the ALS primary gear set. Please consider using them, but we want this to go in as rapidly as possible so that when we reassess, we can see if they're responsive to fluid or not. Once the bag is running, it's probably the best time to consider a second IV site if possible. Reassess your patient, and then we're moving on to the next box where we're going to repeat another 500 milliliter saline challenge if needed. If they're not responsive to the initial 500, it's reasonable to use push dose epinephrine as well as a bridge therapy to continuous vasopressor infusions. Again, we're going to reassess our patient and their response. And if indicated by refractory hypotension, we're going to continue fluids at a maintenance rate of about 250 mils an hour, basically half crack the slider, and start norepinephrine at the initial protocol rate of 10 micrograms a minute. Once we've done that, we're going to continue reassessments. We'll down titrate by increments of 5 micrograms per minute if tolerated. And if the patient remains hypotensive throughout this entire sequence and you need to increase your therapy beyond 10 micrograms a minute, you're going to have to call medical command. Anticipate their potential orders, which could include more push dose epinephrine, more IV fluids, or other treatments. Now that we're indicated for administering highly vasoactive medications, let's discuss special considerations. Large bore IVs in the upper forearm or antecubital fossa are preferred. Make sure it's a flushable catheter with appropriate venous drawback, and consider second access early. Verifying a patent and flushable IV is very important. Norepinephrine can be necrotic on extravasation, so precautions are mandatory. Reassess your line and the extremity it's fusing on before and during administration. Also consider that saline lock or extension set dead space can delay therapeutic care, as it can take several minutes to clear the saline in the lock before the pump infusion hits the bloodstream. To mitigate this, it's the best practice to connect the pump tubing to the proximal Y site of your actively running fluid drip. This will create a driving line, which will allow you to see immediate therapeutic effect. It's also important to note that norepinephrine has compatibility issues with a wider range of medications. Therefore, it's not approved to administer other medications within the same line. Now that we're indicated for administering highly vasoactive medications, let's discuss special considerations. Large bore IVs in the upper forearm or antecubital fossa are preferred. Make sure it's a flushable catheter with appropriate venous drawback, and consider second access early. Verifying a patent and flushable IV is very important. Norepinephrine can be necrotic on extravasation, so precautions are mandatory. Reassess your line and the extremity it's fusing on before and during administration. Also consider that saline lock or extension set dead space can delay therapeutic care, as it can take several minutes to clear the saline in the lock before the pump infusion hits the bloodstream. To mitigate this, it's the best practice to connect the pump tubing to the proximal Y site of your actively running fluid drip. This will create a driving line, which will allow you to see immediate therapeutic effect. It's also important to note that norepinephrine has compatibility issues with a wider range of medications. Therefore, it's not approved to administer other medications within the same line. Norepinephrine can be found in a wide variety of premixed concentration bags. The most common, and the one we will be using, is 8 milligrams in 250 milliliters of normal saline. It's not uncommon to see some emergency departments use the 4 milligram and 250 concentration. You can see up to 16 and 32 in 250 concentrations, but those would typically be seen from ICU to ICU transfers. Vials for reconstitution also exist. For instance, you might see the CCT team utilize these to make field or dirty norepinephrine bags with the appropriate diluent. Norepinephrine can be dosed by weight or by fixed rate. For field use, we'll be using fixed rate. Reading Emergency also uses fixed rate, which can help with report and bridging therapy to inpatient. As mentioned when reviewing the shock protocol, we'll be starting our infusion with 10 micrograms per minute. It is entirely reasonable to expect this plus fluids to be super therapeutic in nature, which is a good thing. We can always titrate down norepinephrine. Titration will be based on increments of 5 micrograms per minute every 5 minutes. Just a reminder, make sure your LifePak non-invasive blood pressure settings are set to Q5 as well and not 10 minutes. If you need to up titrate past the initial rate, you must contact medical command. In general, our maximum infusion rate is up to 20 micrograms per minute, but this can vary depending on command and patient presentation. Infusions above that should be administered very cautiously. Our premixed bags of norepinephrine will be the 8 milligrams in 250 normal saline solution, and they'll come in a foil-wrapped outer package. Do not remove the outer foil packaging until use. Also, it's very important to maintain temperature control during storage, as this medication is highly sensitive to temperature. And again, do not mix anything with the infusion. To program our pump, we'll need the following supplies, which include a sapphire pump, sapphire IV tubing set, and the medication itself. Over the next few slides, we'll review the sequence listed here in depth from start to finish on how to turn the pump on and begin the infusion. After turning the pump on, you'll be asked to select a clinical care area. For field use, we're going to choose 911. And then after that, we're going to choose preset programs. From the preset program list, you'll find norepinephrine, which you'll also select. Continuing the sequence, you'll be asked to verify the drug name, the dose rate, the volume to be infused, or VTBI, as well as the maximum infusion time. If these are accurate, proceed with the next button, where on the subsequent screen, you will verify the concentration. And if that is accurate as well, you'll proceed with the OK button. From here, you'll be presented with an option to prime the tubing and then start the infusion. Please refer to the in-person hands-on training that will be provided to familiarize yourself with the tubing and the priming function. Wrapping up, let's just review a few key points. Prior to infusion, we're going to aggressively fluid resuscitate. We're going to have a plan for therapeutic goals with a map of 65 or 80, depending on the indication. Let's not forget physical exam. We can assess extremities for warmth to see if we do have systemic perfusion. We're going to continuously reassess during administration. Don't forget to set your LifePak intervals for non-invasive blood pressure. We're going to titrate appropriately as tolerated and with medical command if needed. When you get to the hospital, make sure that you inform them of the bag concentration, dosing history, and overall response throughout your care. Thank you for your time and diligence with this training. If you have any questions, please feel free to reach out to your education coordinator or your supervisory staff. Again, thank you.
What is next? Contact an FTO or supervisor or super user to complete the education requirements, which includes a hands-on skills station, written quiz, and a course evaluation. Once these are all completed, at the end of the month, we will be submitting for continuing education for 1 hour for the months of November and December. Thank you and stay safe.